Our speaker today, Dr. Laura Fanucchi, is a board-certified physician in internal medicine and addiction medicine. She provides treatment for opioid use disorder in the UK Bluegrass Care Clinic and in the UK First Bridge Clinic. Dr. Fanucchi's research is integrating evidence-based treatment for opioid use disorder in medically complex patient populations. She has presented regionally and nationally on the management of hospitalized patients with opioid use disorder and provides trainings to physicians and other members of the healthcare team. Dr. Fanucchi is a co-investigator on the treatment team of the Healing Community Study. So everyone, welcome Dr. Fanucchi.
Hi, almost afternoon. Thanks for being here today. I'm gonna share my screen. Let me make sure I have the audio set up properly. Ugh. Share sound, John, is that the one I'm supposed to pick?
Yeah, so that when we watch the video, there's like three little buttons or three little dots.
Yeah. Okay, hopefully that'll work. Okay, so we're gonna go through some behavioral interventions in treatment with medications for opioid use disorder, explain the efficacy of different behavioral interventions in the treatment of opioid use disorder, and describe some of the basics of contingency management, cognitive behavioral therapy, and community reinforcement approach in the treatment of opioid use disorder. Hopefully at the end of this, you'll have an enhanced understanding of the role of behavioral interventions when treating patients with opioid use disorder. So from a high level perspective, why do we emphasize medication in treatment of opioid use disorder? In brief, medications save lives. Counseling alone or treatments that don't include medication are not effective in and of themselves and increase the risk of overdose death. And medication management of treatment for opioid use disorder includes basic counseling. So I think that's a common misconception. Some persons with opioid use disorder certainly do benefit from additional counseling. The problem is that we don't know who is going to necessarily receive the additional benefit, nor what specific modality of counseling will be most helpful for a specific person. So as a refresher, the medications for opioid use disorder, methadone and buprenorphine specifically, save lives. So this is an old study done in 1990 where people who with opioid use disorder who used heroin were randomized to receive methadone treatment versus not. And both groups got a lot of intensive counseling. And this is the number of people that were alive over a span of 8 years. And you can see that the curves separate very, very quickly, and that far more people died in the group that did not receive methadone than in the group that did. Similarly, this is buprenorphine. So this is a study done in 2003. Both groups, so patients also with opioid use disorder using heroin, were randomized to receive buprenorphine ongoing treatment versus a rapid taper. And both groups got a lot of ongoing services, including counseling. And as in the methadone studies, the curves separate right away, and that there was a drastic drop off in the number of people remaining in treatment in the group that had the taper. The group that was maintained on buprenorphine were much more likely to stay in treatment. The other thing that's important to note about this study is that it was a small study, so 20 people in each group. and 4 of the people in this group were dead in a short period of time. So within 2 months of opioid related deaths. This is a very high mortality rate for such a small, for this patient population. So there have been many more studies than just those 2, but those are very clear explanations. And summarizing the studies overall, if we think about the risk of death in the general population at any given time as 1, so we just kind of standardize across populations, the risk of death in the general population is 1. Then people with opioid use disorder are at a much higher risk of death at any given time because of the risk predominantly of overdose. So the risk of death in opioid use disorder compared to the general population without opioid use disorder is about 6 times. And then this is when people are not receiving treatment. And we'll include not receiving treatment as any approaches that do not include medication, buprenorphine or methadone. And so then when we add buprenorphine or methadone to the treatment that patients are receiving, the risk of death in patients with opioid use disorder is reduced dramatically. So it doesn't go down to the risk in the general population, but it goes down to a little bit less than 2. So we'll start with a brief description of methadone treatment. So the way patients receive methadone treatment for opioid use disorder is in a licensed opioid treatment program. And those are highly regulated at both the federal and state level. So in that context, the amount of counseling frequency is determined by regulation. So when people enter methadone treatment in an opioid treatment program, they're in phase 1, and they are required to go and receive their medication every day, and they're required to attend weekly counseling. And as they progress through treatment phases based on their progression, attendance, urine drug screening, and by federal law, they need to attend daily for the first 90 days regardless. They can begin receiving take-home medications and having some fewer visits per week, but still, there's still a counseling requirement that does not decrease to less than monthly as patients progress through phases in methadone treatment in an opioid treatment program. But sometimes it can take people a while to get into methadone treatment, depending on the census that the clinic currently has. So the regulations require a certain ratio of therapists to clients. And so a person might be waiting for a spot to open up, and then they might be assigned to a wait list. But it was understood that being on a wait list and not being given medication actually increases that person's risk of having a bad outcome, never entering treatment, or even dying of an overdose death. And so studies were done to show that if you offer people interim treatment, which with methadone or buprenorphine compared to a wait list, then people do better. And what's meant by interim is simply without the mandatory counseling requirements. So if you're waiting for a spot to open up to meet the requirement for how many patients a therapist can have, you don't want to withhold medication from the person. So there's a federal regulation that allows starting medication without counseling for up to 120 days, instead of saying, no, you don't get any services until a spot opens up. And people who received this interim methadone were much more likely to enter the comprehensive treatment compared to those who were asked to just wait entirely. So really the message here is that counseling requirements shouldn't delay starting medications. When there were also studies done looking at for people that want to enter methadone treatment in an opioid treatment program, but so they were offered to begin buprenorphine in the meantime while they're waiting for a spot to open up in the opioid treatment program. And similar things were found, that the likelihood that a person entered the comprehensive treatment, as well as the number of people being abstinent from illicit opioids or using illicit opioids at all, was much, much, much less in the group that received buprenorphine while they were waiting for a spot in the opioid treatment program. So I'm going to frame the rest of our talk here with a case. So this is a 54-year-old man who has had cocaine use disorder since his teenage years, and he developed opioid use disorder in his 20s. He also has nicotine dependence. He has HIV, hepatitis C, hypertension, hyperlipidemia. He was recently incarcerated and wanted to enter treatment for substance use disorders. And he really identified opioids as the major problem. So he said, heroin's the problem, cocaine I can stop at any time. And I will just say, generally, polysubstance or multiple substance use disorders is very common. And we know we have effective treatments for the most acute, immediately life-threatening opioid use disorder. And so we don't withhold treatment for opioid use disorder if someone has other substance use disorders. So what are our goals in terms of behavior change in substance use disorder? Overall, our goals are to decrease drug seeking and drug taking behavior and increase the time spent in activities with non-drug using social supports. Our motivations for people are complex and sometimes conflicting, and ambivalence is very, very common. So this is totally normal and is not something that anyone who's entering treatment should be ashamed of. It is totally normal to still see some parts of drug use as positive and reinforcing, but that there's ambivalence about drug use and that there's mixed feelings about what it may mean to enter treatment. So if we go back to our patient, so he enters treatment for opioid use disorder and he starts buprenorphine. He stabilizes at a dose of 16 milligrams, and the buprenorphine treatment that he's receiving is in an office-based setting with his primary care provider, and medication management is part of that treatment. And we'll get into a little bit more detail later about what medication management means. So as he stabilizes from his opioid use disorder, he restarts treatment for HIV and he attends his medical appointments as scheduled, but the cocaine use continues. So what are some of the behavioral approaches that we can consider to address the cocaine use as he's continuing treatment for opioid use disorder? So taking a little bit of a step back, what do we understand about adding counseling in and of itself to medical management in outpatient buprenorphine treatment? So remember, buprenorphine treatment as opposed to methadone treatment can be given in an office-based setting like a primary care or a specialty addiction clinic, as opposed to a licensed opioid treatment program. And so patients who are receiving buprenorphine treatment can receive a prescription and go home and self-administer their buprenorphine medication. So there are a number of studies done looking at adding additional counseling to medication management and buprenorphine treatment in the office-based setting. One example is a study by Filene and colleagues, where over 6 months of treatment, they added cognitive behavioral therapy to buprenorphine plus standard medical management, and there was no difference in outcomes in the groups that received cognitive behavioral therapy versus those that did not. Similarly, there was a study looking at cognitive behavioral therapy, contingency management, and we're going to go through all of these in a moment, and a combination of the two. And there was no difference between between the groups over medical management alone. The largest study, called the POET study, happened over 10 sites with 653 participants. They all received medical management with buprenorphine compared to additional individual drug counseling. And again, there was, in all the studies, the intervention groups with more intensive counseling demonstrated similar rates of reduced opioid use as medical management. One of the studies looked at buprenorphine treatment in primary care, and each of these graphs, so you can see each of these lines, the y-axis shows opioid use in the number of days per week, and this is entering treatment at intake, starting medication with buprenorphine over the first couple weeks, and then they have a 6-month ongoing treatment intervention where all groups received buprenorphine treatment. Each line represents a different intensity of counseling approach. So standard medical management is the typical buprenorphine office-based management of opioid use disorder. And then each of these were more intensive counseling. So one was involved cognitive behavioral therapy, and one involved just more intensive individualized drug counseling. And you can see over time, there's no difference in the three groups over the 6-month period. So where does that leave us? Is the message that behavioral interventions are ineffective? No. Medical management and buprenorphine treatment does include basic counseling. So the phrase that I've heard is, some of my colleagues say, is we're not prescription vending machines. We receiving your medication in an office-based setting is part of the treatment visits include basic counseling. So medical management includes the assessment of prescription participant progress in treatment, the effect, how well you're doing on the medication, any side effects that you may have. Treatment is monitored with urine toxicology testing. We assess cravings, withdrawal, and pain, and then we talk through coping strategies for management of craving, withdrawal, and pain, as well as other symptoms and triggers. We work through a relapse prevention plan with clients, and then we screen for and treat or refer for comorbid anxiety and mood disorders. And then we do encourage participation in additional recovery support activities. Some of these may mean community resources like mutual support, like 12-step programs. Some of these may include individual meetings with therapists or with peer support specialists. But overall, the message is that one specific counseling modality or framework or frequency is not necessarily the silver bullet for all patients. So to get into a little bit more detail about what some additional behavioral interventions are, the big picture is that they generally incorporate positive reinforcement approaches. So they're based in the behavioral concepts of rewards and consequences. So what can the group think of, what are some examples of things that might be positive reinforcers in somebody's life that are not substances? So it's lunchtime. Is eating something delicious positive reinforcing? Yeah. Positive reinforcing in someone's life. I mean, this is a basic behavioral concept. What are things that we as humans enjoy doing?
I think that sharing food and reimbursement of services through gift cards, gas cards, that sort of positive reinforcement, contingency management.
Yep. So encouraging the development of activities in an individual's life that are pleasurable and rewarding in and of themselves, and also are healthier choices than drug-related activities. So we'll get into a little bit more detail there, but overall, punishment and shame are not effective behavioral interventions. So basic behavioral interventions are based in the theories of operant conditioning. So I'm just going to define the difference in these types of conditioning. So classical conditioning is the classic example is Pavlov's dog, right? So a previously neutral stimulus, meaning the ringing of the bell, which normally if a dog heard the ringing of the bell, they wouldn't initially think food, right? So that's why the stimulus is neutral. But if you pair the ringing of the bell with a meal all the time, then the brain associates the ringing of the bell with food. And so then if you ring the bell, the dog will begin to salivate, anticipating food, even if there is no food. So that's an example of classical conditioning. So I'm going to give you an example now from human world. So this is a sound that if we hadn't already had experiences with it, might be, while unpleasant, wouldn't necessarily make you have a kind of cringe-worthy response. So maybe not everybody responds the same way, but what is that sound?
A dentist.
Dentist.
Yeah.
That's terrible.
Yeah, I was triggered.
And some
with it.
people probably went, ah, right? So that is an example of classical conditioning where that sound, if we heard it and we'd never been to the dentist's office and never had a tooth drilled and never felt that awful sensation, maybe we wouldn't have reacted like that. But because the sound had been paired with that experience, we have a conditioned response. So that's different than operant, because that reaction is involuntary. So when we went like this, that was completely involuntary. As opposed to operant conditioning, which is where reinforcers and punishments alter the frequency of a voluntary behavior. So to continue our example of the dentist, when you bring kids to pediatric dentists, they give out little prizes, right? And so my kid, or you get to pick from the Chesser test or whatever the things are. So you get a reward. You go to the dentist, you have the unpleasantness, and then you get a reward at the end. So my kids started collecting the little animals that the dentist was giving them. And they don't like going to the dentist, but they like the animals. And so then they wrote me a note saying, "Dear Mom, get us dental appointments." So the operant conditioning of the dentist giving my kids this prize worked. So it was a reinforcer that then my kids not only were willing to go to the dentist, but asking to go to the dentist, and requesting going to the dentist is a voluntary behavior, right? So contingency management is based in operant conditioning in the second example. So where reinforcers and consequences alter the frequency of voluntary behaviors. So Generally speaking, a positive reinforcer is where you add a pleasant stimulus to increase the frequency of a behavior. A prize is an example of this. Money is an example of this. A yummy treat is an example of this. A negative reinforcer is where you remove something that maybe is less pleasant in order to increase the frequency of a behavior. So an example of this is maybe in methadone treatment, you might, patients might, I guess getting take homes is kind of both of this. So it's a pleasant thing, take homes, but it's also removes the fact that they have to go every day, which maybe is something that they're not always wanting to do. Now in treatment, if somebody's not doing well, we say, well, you get to come every day and we get to see you and make sure that you're doing well. And we try to turn what maybe is a consequence into a positive, because we definitely recognize that punishing people does not work. And so more treatment is framed as a positive thing, and hopefully it is, because they come and can get additional rewards. So a consequence might be adding something that's unpleasant or more unpleasant to decrease the frequency of behavior, which we try not to do this kind of thing in treatment, because we do know that negative things are not reinforcing in this way. So in substance use disorder treatment, we might, in contingency management, we would identify a target behavior, for example, an appropriate urine. So reducing use of whatever drug it is. So in the case of the patient that we're talking about, he's doing well from an opioid use disorder standpoint, but he's still using cocaine frequently. So we might target the frequency of cocaine use, having appropriate urines without cocaine in them as a target behavior. And then you need to have a way to measure the behavior. So in this case, it's urine drug testing. And then you want to have tangible reinforcers. So the positive reinforcers are tokens, a clinic privilege, a gift certificate, and you can have escalating value of rewards. And then the rewards are withheld when the behavior doesn't occur. So I have a little video to play that is an example of contingency management. Let's see if this works. Show an ad.
Those emotions, they were put on hold by time, by careers being built. But at Claire's bridal weekend at a Verbo beach house.
For 4 weeks, that means you get 5 drops. Sound good?
Yeah, sounds good.
Excellent.
All right.
Okay.
We can't see the video.
Bucket.
All right.
Okay, first draw. What do you got?
Small.
Good job.
All right.
Nice. Come back in there. What's this?
Small.
Small? Great. Good job. We're going to do 2 smalls. What's this?
Large. Hey, alrighty. That's one I like.
Good job. So that's 2 smalls and a
Dr.
large.
Fanucchi, we can't see the video.
You look at our cabinet.
Should I try again?
So I think it's because you were probably sharing an individual window. So if you share the window with the video.
All right, sorry, we'll try that again. There, is that working?
Yes.
Okay, we'll go back to the beginning.
If you can start it at 35 seconds.
Here?
Yes.
That's it, okay.
4 weeks, that means you get 5 drops. Sound good?
Yeah, sounds good.
Excellent.
All right.
Okay. So you shake our bucket.
All right.
Okay, first draw. What do you got?
Small.
Good job.
All right.
Nice. Come back in there. What's this?
Small.
Small, great, good job. There was actually 2 smalls.
Can we get a different color?
What's this?
Large.
Hey,
Hey,
good job.
alrighty. That's the ones I like.
Good job. So that's 2 smalls and a large. So we'll stand up here and
Okay.
have you look at our cabinet.
Okay. Alright.
There we go. Sorry, got a closed door.
Oh, hey.
And grab yourself 2 smalls and a large fries.
Okay, small here?
Mm-hmm.
Okay. Oh, wow. What a decision. I don't need no mac and cheese, though. Oh, I'll take 2 kids. Oh, where's these? Oh, no. This, the lips. I'll
Excellent.
take lips. Okay.
And you can get another small too.
So one more small. Is that a whole cup full of goodies?
Oh, they're just 1 each.
Just one each. Okay. Oh, well, oops. I'll take the gloves.
Great.
Can you
Excellent.
close this time of year? Okay.
And a large?
And a large. Is that this shelf?
Yep, that's that second shelf.
That's that one there. Okay. What is this here? Oh, we'll take this one.
Fantastic.
Okay.
Okay. So that was an example of, oh, what is happening now?
Soup, and that'll be.
Sorry, YouTube just has a mind of its own, I guess. Okay. So that was an example of contingency management in clinic. So the person had had a certain number of weeks of appropriate urines. And so the number of draws out of that bucket increases as the number of weeks go on. And so the likelihood that you're going to get a higher value token and can pick from the shelf that has the bigger value stuff in it increases with the number of weeks that their appropriate urine. So then if the participant has a slip or returns to use, then the number of weeks will reset. And they, instead of having maybe 5 draws out of the bucket, they might have 1. So that's an example of how that might work. So this was a study of contingency management in opioid use disorder treatment with people that had also cocaine use disorder. And it was 162 patients in Connecticut, and they were divided into 4 treatment groups. They got buprenorphine or methadone, and they got contingency management or performance feedback, which performance feedback is basically just telling people what their results of the urines are and being encouraging if somebody's urine is appropriate. And so in the initial 3 months of treatment, you can see that methadone plus contingency management was most effective in increasing the proportion of drug-free urine tests in successive intervals. So the red bars are methadone treatment and the green bars are buprenorphine. For buprenorphine, also contingency management was a little bit more effective than performance feedback. But at the end of the 6-month study, there weren't a ton of major differences between the 4 groups. Contingency management for illicit drug use during treatment with buprenorphine or methadone. So overall, there was a large meta-analysis, which means that a lot of studies were combined and statistically analyzed to see if there's an overall effect. And the studies tested contingency management for substance use reduction or abstinence in people receiving medication for opioid use disorder. The studies included all randomized controlled trials, and the reinforcement had to use biological verification of substance use. And the measures were also consistent. And it didn't include any studies where people were not voluntarily participating. And overall, contingency management demonstrated an improved duration of abstinence and the proportion of negative urine samples compared to non-contingency management approaches. So if we continue our case, he's 6 months into treatment. Some things are going well. So he continues on buprenorphine. He has no illicit opioid use. He's doing well in terms of treatment of his other chronic medical issues. He has housing. He's obtained a part-time job. But some challenges continue. So he has near daily cocaine use, and he's still smoking a lot of cigarettes, and he wants hepatitis C treatment, but feels like maybe it's too much. There are some concerns with his job and that his new co-workers are using alcohol. And so he's starting to develop some insight into the ongoing cocaine use being more difficult than he originally thought. So how might we use contingency management in practice as part of buprenorphine treatment? So we have our positive reinforcers. We have the buprenorphine, which the medication itself is a positive reinforcer. People feel better on the medication. That's definitely a reinforcing, and that's a positive thing. It is a good thing if people feel better on the treatment that you're giving them. When he comes into clinic visits, he's provided bus passes. He gets meal passes to go down to the cafeteria, maybe some snacks to have while he's waiting. But there are some we'll put these in the reinforcing category, but they are technically consequences. So we ask him to come back more frequently. He has some supervised dosing of the buprenorphine and starts having shorter scripts, but we frame it as, we really are worried. We want to see you more frequently. We want to help you meet these goals. We work through together. He identifies that his goals are to be able to reconnect more with his family, to spend more time with his grandchildren, to have his daughter feel comfortable with him watching the grandchild. And so these are all things that he's identified in his life that are goals. And then there are some reinforcing activities for him that if he meets the contingencies of having less cocaine use, he gets to have fewer visits, he gets to have more take-home doses, and he gets to have longer scripts. I put this in here because this medication he requested for erectile dysfunction, and we actually turned it into part of the contingency management because ongoing cocaine use and smoking are very strong drivers of erectile dysfunction. And so we could use it as a positive reinforcer. You can absolutely have a prescription for this medication once we start to see reductions in cocaine and tobacco use. So 2 years into treatment, all the previous things are still going well. He was able to get through treatment of hepatitis C, and the hepatitis C was cured. He decided to go to residential treatment for the cocaine use disorder, and he went actually twice to residential treatment and entered an 8-month-long remission from cocaine use, which was the longest stretch for him when he had not been incarcerated. He was reconnected with family and had successfully decreased the number of cigarettes that he was smoking. So some challenges did continue. He did have some returns to cocaine use, and he had some depression. We added a medication to help address the depression, and he began intensive outpatient treatment. So a common therapeutic modality that he experienced in intensive outpatient treatment and is commonly, like if patients are referred to counseling as part of their treatment, they will commonly participate in cognitive behavioral therapy. And so I want to separate that as a therapeutic approach as opposed to a behavioral intervention. But just just in brief, it's a group, it can be provided in a group or individual therapy, and it addresses interpersonal and social environmental influences that maintain the substance use problems. And there's a focus on coping skills, on cravings and trigger management, and on developing new reinforcing behaviors in life. So this is another term for this would be developing alternative reinforcers that are not drug use, but that the person derives pleasure from and that they are positive, healthy behaviors. There's also a focus on increasing self-efficacy. Another common behavioral approach is called community reinforcement. So this is where the individual works towards a pleasurable and healthy lifestyle that is more rewarding than one that includes drugs. So it's a structured treatment approach, and it includes exploration of positive and negatives of substance use. It works with the client to identify, again, the new reinforcing healthier behaviors, and hopefully moves towards satisfaction with various areas of life and goal setting. And it incorporates skills training, so communication, jobs, and trigger management to help the individual change their, develop healthy relationships, apply for and hopefully keep jobs or other employment. There's another strategy called community reinforcement and family training. So this is a modality where the therapist will work with a person called a concerned significant other. That is a scenario where the significant other actually is brought in, and they are taught by the therapist contingency management to use actually at home and continuing to promote the positive behavior change. So this is originally developed to help people enter treatment, meaning people that had been ambivalent about entering treatment, and there's concerned family or friends that are taught to promote the behavior change at home to help the person enter treatment. And the approach was adapted to improve retention in buprenorphine treatment. So if a person is in treatment already with buprenorphine, but maybe having trouble staying in treatment, this approach would leverage the relationship that the client has with the concerned significant other. What's important here, and both with another approach we'll talk about in a minute, is that the significant other has to have the client's best interest at heart and has to be on board with the overall treatment approach, including medications. And so it's important that that person receives ongoing education and engagement from the therapist that's leading the treatment. Particularly as we're hopefully coming out of the pandemic, but here we are still doing everything over Zoom. We wanted to bring up that there have been more interest in virtual approaches. This was beginning before the pandemic, but there's been particular attention because of the use of telemedicine and such. And so this is an example of virtual community reinforcement plus contingency management. It's a program that now is FDA approved through an app. It's called Reset-O. But the study was done that got it FDA approval. It has 60 plus interactive modules for the participant to focus on that is based on community reinforcement. And it focuses on skills building and alternative reinforcers. They're interactive modules. And then participants can win monetary incentives through the app, basically contingency management. So they can earn incentives with appropriate urines as well as completing the modules. And there's an interface for the provider to see how the participant is doing and and to work together in that way. And so you can see that in the study, this is treatment as usual is the dark or the solid line. And this is they called it at the time, the therapeutic education system. And so there was improved retention in the people that participated in the virtual environment compared to treatment as usual. And everybody was on buprenorphine treatment. This example is network therapy. So network therapy is a manual-based behavioral therapy, which like community reinforcement and family training, this one brings network members. So as part in the beginning of the treatment, a network member, family or friend is brought in to the therapy sessions to provide a supportive environment to support remission and recovery and continue the activities that are done in the therapy session into the community. And so there was a study looking at comparing to medication management and buprenorphine treatment. And I have an asterisk here because when the study was done, it was a few years ago. The participants were tapered off buprenorphine in both arms, which is not recommended. And it definitely leads to reduced retention and increased risk of bad outcomes. But in this particular study, patients were tapered off the buprenorphine in both groups. And so people that were participating in network therapy did have a higher proportion of opioid negative urines during the treatment interval. So in summary, medications for opioid use disorder save lives. Counseling alone should never be offered instead of medication for opioid use disorder as a required first step. But behavioral interventions are a standard part of medication for opioid use disorder treatment. Medication management, which does include basic counseling in buprenorphine treatment, is effective without additional specific counseling modalities. But we still recommend counseling and community recovery supports generally to our patients. But we don't recommend participation in those groups that don't, quote unquote, believe in medication.